Hey everyone, back again. My name's Cody Summers, and I am an ICU nurse that's passionate about pharmacology in critical care. I believe it's very important for all of us as nurses to understand how medications work and why we give them, as I've previously said in other videos. And today we're going to be diving into Milrinone, which is sometimes a scary or intimidating medication for new graduate nurses or nurses who don't have any experience using the medication. But it's a very helpful medication, especially in certain patient populations. And it's one of our go-to inotropes in the ICU for patients specifically with heart failure or cardiogenic shock. So let's break down how Milrinone works, when we use it, and what you need to know when caring for patients on this medication. And hopefully by the end of the video, it'll be a little less daunting. So Milrinone is a phosphodiesterase 3 inhibitor, which means that it's not a catecholamine like norepinephrine or epinephrine that we've discussed in our previous videos. So, big picture, Milrinone inhibits the enzyme phosphodiesterase 3, which breaks down cyclic AMP inside cardiac and vascular smooth muscle cells. And so by increasing cyclic AMP levels, it causes increased calcium influx into cardiac myocytes, which improves contractility while also promoting vasodilation in vascular smooth muscle. In simple terms, Milrinone helps the heart pump stronger, but it also reduces afterload, making it easier for the heart to eject blood. So, indications and kind of clinical uses of Milrinone. Milrinone is primarily used in cardiogenic shock, acute decompensated heart failure, and is sometimes post-cardiac surgery when the heart needs temporary inotropic support. It's especially useful in patients who are on beta blockers, since Milrinone doesn't rely on beta receptor stimulation like Dobutamine does. And so we'll often see it used in combination with vasopressors like norepinephrine to maintain perfusion while improving cardiac output. So for dosing and administration, Milrinone is administered as a continuous IV infusion, as I'm sure you guessed. Traditionally, some protocols start with a loading dose of 50 mics per kg over about 10 to 15 minutes, followed by a maintenance infusion, usually set by the doctor, of 0.125 to 0.75 mics per kg per minute. And it's not one that we typically titrate due to its long half-life and its potential for profound vasodilation, especially in unstable patients. However, what I've noticed in the medical ICU where I transferred to, we often skip the bolus dose to avoid hypotension. And as I previously mentioned, just because of its long half-life, which is around 2.5 hours, as well as, another indicator, or another thing to speak about is its renal clearance. Doses should be adjusted for renal impairment. Otherwise, it can accumulate and cause prolonged hypotension or arrhythmias. This is especially something that we see in the medical ICU with patients with acute kidney injury and things of that nature. So these are just important things to keep in mind when using Milrinone. So some common adverse effects obviously include hypotension and some arrhythmias, especially ventricular. And also, if your patients are not intubated and sedated, a headache can ensue due to the vasodilation. So because of its vasodilatory effects, Milrinone can drop systemic vascular resistance significantly, which can worsen hypotension if not balanced with a vasopressor. We must use it cautiously in patients with severe renal dysfunction, as I previously mentioned, or low preload states. And it's important to remember that it is not ideal for patients with fixed outflow obstructions, such as aortic stenosis. So let's look at a quick case study. You're in the ICU and you're caring for a 68-year-old male with an acute myocardial infarction who is now in cardiogenic shock due to this. His blood pressure is 82/50, and after getting an arterial line in and hooking up FlowTrack, you see that his cardiac index is 1.5, which is on the low side. And let's say he's already on norepinephrine for MAP support. The provider starts the patient on Milrinone at 0.25 mics per kg per minute to help improve contractility and reduce afterload. Over the next hour, the cardiac output rises to 2.4, which is good. His MAP stabilizes as you increase some of his norepinephrine just to kind of combat some of the vasodilation, and his urine output improves, which these are all signs that his perfusion is improving. This case study just kind of showcases how Milrinone can be a great adjunct when the issue is poor contractility with high filling pressures. So one thing that folks often get tied up with is comparing it to Dobutamine, which is kind of what I'll talk about here. When comparing Milrinone to Dobutamine, there are a few key differences to remember. So if you'll remember the mechanism of action with Milrinone, it is a phosphodiesterase 3 inhibitor, while Dobutamine is actually a beta-1 adrenergic agonist. So Dobutamine is kind of dependent on being able to stimulate those beta-1 receptors in the heart, and so if patients are on beta blockers, Milrinone may be a better option here since it does not rely on the activation of those beta-1 receptors in the heart. As for heart rate, Milrinone usually causes less tachycardia than Dobutamine. With regard to afterload, Milrinone causes more vasodilation, which is important to remember and be aware of, which reduces afterload, while Dobutamine can increase heart rate and sometimes increase myocardial oxygen demand. And then as we mentioned with the beta blockers, Milrinone works independently of beta receptors, making it effective when patients are on beta blockers. But in short, both improve contractility. Both are great inotropes, but Milrinone is often chosen for beta-blocked or post-cardiac surgery patients, while Dobutamine is preferred when we rapidly need to titrate or a shorter half-life is desired. So some of the key takeaways, just to kind of wrap up here. Milrinone is a very powerful inodilator that increases contractility and reduces afterload, which improves cardiac output in patients with cardiogenic shock or advanced heart failure. We need to always remember to monitor hemodynamics, renal function, and rhythm closely to balance Milrinone's vasodilatory effects with appropriate volume status or vasopressor support. And so hopefully you guys feel a little bit more comfortable with this medication now that it's been explained a little bit better than sometimes it is. But I want to thank you guys for watching, and I hope my overall goal is to help you feel a little more confident when caring for patients on these advanced medications, and so hopefully that was accomplished with this video. All right, thanks, and I'll see you guys in the next one.